Okay. Good morning. Welcome to Friday morning conference. This is going to be a very exciting one today. We're going to learn about an area of medicine that is essentially new to most of us, I think. It certainly was to me when I started looking into it. Dr. Joey Banks is with us. She is trained in family medicine and has done work in Alaska with both the Indian Health Service and Planned Parenthood. She is currently precepting the family medicine rotation on women's health as a primary care physician and medical director of reproductive services at Blue Mountain Clinic. She's been working with the trans population for a number of years here in Montana because she recognized that this was an underserved population. She has attended education conferences on the topic to improve her knowledge.
Good morning. Is that loud enough for everybody? Okay. Thanks for having me. Do I have to stand anywhere for? Okay, thanks. Thank you very much for the introduction. Like she said, I'm as expert as I can be in this topic in my small number of years, 3 to 4 years, practicing with the trans community. And I would say before I moved to Missoula, this was not part of my practice. So it's interesting to be asked to speak on it when I myself am constantly asking to go to places where I can learn more about this topic. So I'll share what I have knowledge-wise. This isn't meant to be the 101, I get out of here and I know everything I need to know about taking care of this population, because you can't do that in 45 minutes and because you don't need to. It's all available for you online when you need it. And so I use a number of really great resources that I go to every time I have a question that I need answered. And so I'm going to share some of those with you also. And then just talk about why in Montana you need to have it on your radar more maybe than you have had it on your radar in the past. There's probably one of these with the clicker. All right, my disclaimers are I am a Nexplanon master trainer. That has nothing to do with this talk, but I am that. And then I stole some slides from the residents with their permission. So Megan and Cassandra are doing, I think, a lecture next week at the AFP Montana conference. And it's a little bit more basic 101 case study. How do you do the medicines? How do you do the labs? So just my history, how did I come to even being a person who provided this kind of medication or this kind of treatment or this kind of referral basis? I was born in Oklahoma, so Catholic family. I'm actually Delaware Native American. And I went to Baylor University, which is a Baptist college, and I was a cheerleader, so I could high kick after the thing if you wanted me to. And after that, my husband and I went to Africa, West Africa, and we were in the Peace Corps. And when we came back from that, I went to residency or med school, and then I went to residency in Alaska and chose family medicine because I see taking care of the whole family is my heartstring, kind of what pulls me the most. I worked at Indian Health Service. I was a Planned Parenthood medical director, and that's where I got into reproductive services some. We went back to Africa and lived in Tanzania when our children were born for my husband's work, so I worked a little bit more in Africa. And then we came to Missoula, and we could choose anywhere in the world we wanted to live when we were moving back to the States, and we chose Missoula because of its open-mindedness and its scenery, and we just have made friends very quickly here. And so, and partly because of Blue Mountain Clinic. And Blue Mountain Clinic for me is a place where I can practice medicine for maybe populations that are having difficulty finding physicians for the services they need. So how does this get me to trans medicine? Well, trans medicine is a tiny part of what I do. I do reproductive medicine. I do regular family medicine. I do regular old sore throats. I do vasectomies. This journey got me to trans medicine because when you journey like that, you realize the world is made up of thousands and thousands of different people. And they are different colors, and they are different religions, and they are different cultures, and they are different genders, and I can't even explain how open the world is to me as far as how many different people there are in the world. And so for me, jumping into trans medicine was just one more person I was serving in this vast culture of people in the world. And so I think it just made it was an easy kind of flow for me. When we first got to Blue Mountain Clinic, I was lucky enough to get to partner with the Gender Expansion Project here in the city that does hold a transgender conference every single year for education and knowledge. And I also partner with Open Aid Alliance and with the residency, so I help teach at the residency some. And so those also kind of said, you can do it, go forward, learn a little bit more. So why does this matter in our world of Montana? So our population's a little over 1 million. We know that it's on the news, it's on the television, it's in the schools. This word transgender and the concept of being someone who identifies with some gender fluidity is a lot more common than it used to be even a year ago. Even this last year, it's really risen to the forefront again. The public school system is starting to add it somewhat into their health curriculum. Some schools more than others. Sussex and MIS are adding it pretty regularly now to their health science courses. 0.3 to 0.5% of people might identify themselves as transgender. This comes from the Williams Institute. This study is a little bit old, like a 2009 or something like that. And so as people are able to unsilence their own feelings or beliefs, that number will probably rise. That's a mostly adult survey also. And since it's 5 to 6 years old, it probably doesn't signify what is true today. But that would mean in Montana, 3,000 to 5,000 people might identify as transgender. We know that about 7% of the population identifies themselves as gay or lesbian or somewhere in that gender scale here in Montana currently. And if you ask medical professionals, many of them would say, well, I don't feel like I have enough training in that. I know I got nothing in residency, nothing in med school, nothing at any CME until about 3 or 4 years ago. And so, I think what we have to remember, though, is there's lots of things we don't have a lot of really good training in because medicine changes so much, right? I always use that. We used leeches. We didn't use leeches. We use leeches again. Who knows if we're supposed to use leeches? It's probably going to be associated with some risk later in life, and we shouldn't have used them, but we used them. So we always have to learn new medicine, and this is just one new forefront that I think most providers should be somewhat aware of, even if they're providing or not providing. Most of you have probably seen something like this. How many people have seen something like this before? I know all the residents have. And this is gendered person, and especially when I'm talking in the schools or I'm helping families that are working with their own children with gender fluidity issues, we bring this out a lot. And we talk about gender identity as being an expression of a whole bunch of things. So you have your actual gender identity. How do you see yourself? More womanness, more manness, more in the middle? And then also, what is your biological sex? What is your gender expression? How do you want other people to perceive you, right? And who are you attracted to? And so when you put these four together, the combinations of the four are incredible. A film we watched last night called Put This on the Map, that we were showing last night, Put This on the Map, showed me a part of transgender world that I knew, but I hadn't seen that up close before. So a person who is transgender, biological male, transgender hormone therapy to become female, and now decides I am attracted to other females, and is battling that am I gay or not gay struggle, and that's a hard part because her parents that were supportive in her becoming female now are taking a step back again and going, hey, we embraced all this, but now, oh, we weren't ready for you to actually live as a gay person. And so there's all these dimensions as to how a person can express themselves. Remember that attraction and how you identify yourself, or attraction and what your biological sex is, or attraction and how you express yourself, are never hand in hand. And the hardest part, I think, in transgender medicine, when I'm sitting down with a client for the first time, is to take like any assumptions about who a person should be or who I see them as by just looking at them, and take those out of my head and like start from the beginning and get to know that person. And I think when you work in hospitals, especially like urgent care, emergency rooms, things like that, you don't have time really sometimes to get to know that person. And so you have to be very quick at moving your assumptions of what you see out of the way so that you can get to the heart of the person and the problem. So just basic language around transgender medicine, just so everybody's using terms that everyone knows. I have to say, when I'm meeting a client for the first time and I'm uncertain about what their past medical history has been related to transgender, sometimes I'm uncertain, have they gone, what transformational surgeries they've gone through. The more open and honest you are, the faster you get to what you need to know, and you can just move on. Using correct language helps you get to that place a little bit faster. So transgender person is a person who sees themselves as not being born in the correct biological body. I am cisgendered. For me, I feel like the biological body I was born in is the gender that I feel, that I identify with. Gender fluidity, that term I use a lot. It's for people that are somewhere in the journey of trying to determine where they are, or actually their gender is fluid. They see themselves as maybe male, as maybe female, as maybe being able to go back and forth. Gender queer or non-binary, or there's a whole bunch of terms for this, are people that say, I have no gender. Stop giving me any gender, or I'm completely comfortable with both genders. And then intersex is not really a transgender term, but I bring it up so that people are aware. Intersex are a huge broad definition for intersex too. Within the intersex community and within the medical community, intersex are people that are born with ambiguous genitalia, or external characteristics of one sex and internal organs of another sex, or have enzyme deficiencies like androgen insensitivity, enzyme deficiencies that make their outward physiological body not match what their internal organs are. And intersex is actually about 1 out of 2,000 people. I don't think people realize that, but about 1 out of 2,000 people are born with ambiguous genitalia. We used to think in the medical world the best thing to do for intersex people was to very early help that family decide how they wanted to assign that child, and then go through either surgery or hormone transformation so that very early on that intersex child grew up with an identity. The medical world now feels that was probably not, that was the Leach thing, it was probably not very good, and that we should wait until that child is able to express for themselves which identity they see themselves in. And so intersex people today that I have in my practice are people who were assigned a gender based on what their parents thought was best for them in a good-hearted way, but have identified as sometimes the chromosomal sex they are, or as another sex. And now kind of meld into that transgender world, because it seems like they're going through a sexual reassignment, but they might be going back from a sexual reassignment back to what they initially identified themselves. But the medicine we use around intersex people can be very similar to my transgender population. However, remember, intersex, some intersex people do not consider themselves transgender because they feel they are going back to the gender they were supposed to be. And so you just have to watch your language when you're talking with people, so you make sure you're using language that they feel is appropriate for them. I like this on the side, I do not identify as. So the transgender world often has to go in and say, I was born biologically male, I identify as a female, I have not had surgery. And they get tired of saying, I identify as, because the cisgendered world doesn't have to walk around saying, by the way, I identify as a female. And so remember that just because they are identifying, sometimes this kind of language, what is your preferred pronoun? You know, sometimes that can feel off-putting to people. And so sometimes you need to ask, but remember that sometimes their whole identity is just, I am a person like you are a person. Stop asking me to identify as something. Does that make sense a little bit? Transitioning language, coming out might be coming out to family, friends, or school. So I have a 6-year-old now that I'm seeing in clinic that is considering changing from kindergarten to first grade, coming out as a male, has not decided to be called a male pronoun yet, has not decided to change name yet. So today we are still calling she. But she is considering with her family transitioning as outward expression to a male starting in school next year. And so our discussions have been around how do we make that happen in the public school system in Montana? How do we make it happen in a way that's safe? It's always a discussion with the teachers and the principals about bathrooms to start with. And you're going to be seeing much more frequently that almost every public school has gender fluid bathrooms as well as male and female bathrooms. And a lot of work is being done in the public school system right now to make that a safe place for people who identify transgender. And do we switch schools? Is the friend base enough that you can come out to those friends, and or is it going to be easier to switch schools and come out as a male with people who have only know you as a male now? We had a call from Kalispell the other day for a student that was 9. They were asking some of those questions about safety for this child, and wouldn't it be better to really convince this family to move from Kalispell to a different city and let that child come out as only that new gender in the new city, and just talking about safety around that. So when you have children and families presenting, those are some of the issues you're going to start with. Counseling. For this family, we talked about counseling. We talked about counseling for the whole family because the parents are still really wrapping their brain around this. We talked about counseling for the child because the child does, at this stage of the game, still feel very confused by it, and still has this feeling of, am I doing something wrong because this is confusing for my family? And also to start to talk about what it's going to feel like when barriers hit this child that they are not expecting, whether it be bullying or whether it be physical violence or whether it be depression or whether it be discrimination or whether it be none of that happened and life is great, but I thought all this was going to happen because everybody told me it was going to happen. And so we all know that counseling is probably something that everyone in the entire world should do kind of all the time, like going to the gym. And so I don't think it's any different for this population. The old school thought that counseling is required for a certain number of months or a certain amount of time to say, ding, 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 you have finished your counseling session. I agree, you are absolutely trans male, is not required anymore. However, the rate of suicide and depression in the transgender community is 41%. I mean, this is huge. And so encouraging people for counseling is very important, not to help them figure out are they truly transgender or not, but so that they can fight that discrimination or battle or sometimes internal turmoil they have. Hormone therapy, we use puberty blockers just like we use for precocious puberty in youth when they reach 10 or 2 or 3 to stop their puberty, and then at 14 to 16 start trans hormones. We'll go through hormones a little bit. Genital reassignment and affirming surgery or other physical interventions like laser, hair removal, and then legal changes. And so remember, in this transitioning journey, any of this can happen in any order. Some people are very quick to make legal name changes before they even get on hormones. They are coming out and dressing in their preferred expression of dress, but they are legal name right away changed. Other people, legal name change doesn't even come until after sexual reassignment surgery. And so there's no specific order to this. So you'll have to ask people when you meet them newly, where are you in your journey in life in this step? Tons of organizations have guidelines. So it's nice. And every year, more and more organizations are coming out with guidelines. AAFP, mine, doesn't have a guideline yet, starting to work on it, but no specific references. But the Gay and Lesbian Medical Association has nice guidelines. The Endocrine Society has nice guidelines. WPATH has an actual downloadable, printable guideline book now that you can just print right off the internet, have in your office at all times. American Psychological Association just May of 2015, I think, came out with guidelines around gender dysphoria. And that is what we are using as the ICD-10 code, gender dysphoria. I think it's like F68.1. Does anyone have it memorized? I think it's F68.1. I have it somewhere in my slides. And then there's a different one for youth. So F68.1 is young adults and adults, and then there's a different one for a youth, 68.4 or 2 or something. American Psychological Association just switched from being gender identity disorder to gender dysphoria. You can also use endocrine disorder not otherwise specified if you need to also. Sometimes I do ask my clients. Some of them are very up to date on what ICD codes are, and they want the same diagnosis on every single medical record, and it's important to them. And they don't want that identity disorder written down. Other people don't care at all. Gender expansion projects. And so if we go, just to show you briefly, some of the sites. This is my favorite site for medical knowledge, UCSF, Transgender Excellence. And the reason I love this, and so when people come to say, and they say, teach me, I say, go to this website. It is your teacher. I can teach you, but go to this website because I still go to it all the time. I go to it all the time. This website, if you go in to assessing hormone readiness, you can go right to the bottom and print up consents. And I don't make my clients at all sign any kind of written consent because I don't make my female patients that are on postmenopausal hormone therapy write a consent. I don't make my hypertension patients that are on medicines write a consent. And so I do consents for procedures. Giving medications to my mind is not a procedure. However, I will quite often pull up a consent because it's a really easy way to go over risk and benefits right in front of a person. And so I can say, hey, let's go over all the risks and benefits, and I can just read them off. I can read off, here are risks, here are benefits, here are permanent changes, here are non-permanent changes, here's the speed at which things may happen. And I don't have all that in my head because my population for transgender clients at Blue Mountain Clinic right now is maybe 45, 50. And so I see a lot more well-child checks and a lot more things that are in my head like this than I do with my transgender. So if I pull this up, I make sure I'm not missing anything for them. So it's giving me, that could be my old age too, that I need to pull that up a lot more often than I used to. But and the other thing I like is when you're starting transgender care for a person, the one thing I hear a lot is people are very nervous to start the medicines without all the labs and all the past medical records and all the, and I would have to say, remember, 41% of transgender people up to 41% can commit suicide. And part of that is discrimination within the medical society or physicians withholding medical treatment. And sometimes we're doing it with the best intentions, but really a cholesterol that's elevated today, and I give you your estrogen, versus I make you wait another 2 weeks to get those labs back and come and see me. Have we made like a huge cholesterol change by then? I mean, we're still going to give the medicine. So every time you withhold, it feels like this is a struggle. And for the older transgender population, this has been a struggle their entire life. And so you can very quickly make that a difficult relationship when really we are not meant, physicians, providers, nurses, doctors, PAs, whatever, we are not meant to be people that can hold people hostage for medicine. You know, we are meant to provide the best medical advice and care we can, give all the risks and benefits, but we're not supposed to be the ones like withholding medicine. And so I feel very much that in our clinic, we're a little more open to say, I see this, you've done this journey, blah, blah, here's some labs I'd like to check. Here's the risk and benefits of starting medications without knowing this lab work. Some people are like, please, please, I've been in this struggle long enough. I really want to start, and I'm coming back. And so we just start the medicines that day, draw our labs that same day, and have our follow-up. Other people say, oh, no, I want to know all my risks beforehand. I want to take care of my body in the safest way I can. And so, yeah, I'd like to look at my cholesterol, and then we can decide which estrogen is best for me. So just find out where that person is in maybe what struggles they've had. You can also go to the actual medications themselves. So you can go right to hormone therapy. You can go to special things around elderly that are starting transitioning, youth starting transitioning. So this is my favorite site. We all have to leave. Okay. So true fire alarm. Do we? Tell me when. Okay. So I'm going to slide through slides really fast. What we might end up doing is going so fast that I come back in another time and break it down a little bit more basic into what you know, so that after this, if you have, hey, we really want to talk specifically on this part of transgender care, then maybe I can come back, or another expert from the community can come back and give that specific part of the talk. If you need to leave, leave. Feel free. WPATH came out in 2011 with requirements for initiating hormone therapy. And the interesting part is they took away the absolute counseling. Counseling is still suggested, but they took that away as like a requirement. And they also took away having to have a real life experience for a certain amount of time, meaning dressing in your gender expression outwardly, coming out as a certain amount of time before starting cross hormones. And I think that was a great thing that they came out and said, because I think many people, it's that year of trying to express yourself with identity on the outside that doesn't match hormonally your identity and doesn't give you the true physical characteristic changes that hormonals can give you, that can lead to that increased suicide. That year is a really tough year for people. And so now being able to say it's okay to initiate at the beginning of the real life experience, at the beginning of living the way you're supposed to, is probably a better thing for an overall person's health than not. Remember, I'm always telling residents, guidelines are just guidelines. So every person is different, every clinic is different, and guidelines are wonderful, but remember the word guidelines is guidelines, not absolute 100% protocol. So people should have a capacity to make a fully informed decision, and they should have a persistent, well-documented gender dysphoria. Someone asked me, how would a 6 or 8-year-old know? It's coming in a slide a little bit more. Some of the clues around 6 and 8-year-olds are saying words like, I am a boy, but for a person who was born biologically female. Not I want to be a boy, I am a boy. So we'll go up to a teacher and say, not I want to be a boy, I am a boy. Underwear battles, swimsuit battles. When I grow up, I am going to be dad. So persistent words about what they are and see themselves as in the future. And then even sometimes harmful language like, if I get a penis like dad, if it's a trans female, I'm going to cut it off, you know. And it's a persistence around that. are some of the clues. And then transgender suicide. And I just bring that up again because if you're waiting for a certain number of check-off things to do before you agree to write hormones for someone, you're putting them more and more in this risk that we already know is an actual risk. And we know that top 4 causes of transgender suicide are misgendering, discrimination, rejection, and victimization. And it's something like 12% of transgender clients say that at one time they've actually been refused medical care based on their gender identity, whether it be in an ER, whether it be in an urgent care, whether it be in a primary care office. Sometimes around the ruse of, I don't really know this kind of medicine, and so you really need to see this other doctor who, quote, is a specialist. When you start to look at how to prescribe the medicine, it's not specialist work. I mean, the actual medicine part, anyone can do. I'm so grateful that I have my endocrinology specialist that I can go to for my difficult cases or the people that have this plus this and also have hormone issues, because I don't know all that. But the actual, here's your testosterone, or here's your estrogen, or here's your referral to a surgeon that does breast removal, that part's easy. And so transgender people get that sometimes, that there are physicians or medical professionals that say, I can't do that because I don't really understand it, but what they're really saying is, I don't feel comfortable with it, you know? And so just be open and honest if you feel like your knowledge is lacking. But say, I really want to help too. So a list of hormones that you can use. I literally go to that USCF website when I'm talking with clients, sometimes with it in the room if I bring my laptop in, so that they can really see specifically what the options are. And there are a lot of options. It all comes down to cost a lot. And so right now, estrase sublingual oral is the cheapest out there when it comes to estrogen. Transdermal patches are great, provide a lot less DVT risk. You can get generic cheap, but you have to apply 2 to 4 patches sometimes to get the appropriate dose. And it's hard enough to wear 1 patch every day, but to walk around with 4 patches is difficult. And so I end up using a lot of IM, estrogen, or estrase because that's what is cheapest right now. Testosterone right now, the gel testosterones are extremely expensive right now, and so we end up using testosterone IM or sub-Q. And it does come down to cost, sometimes more than benefit-risk ratio. There are testosterone pellets that you can use and can be in for 3 to 6 months, depending on dosing. But you have to know how to put the pellets in and how to use the trocar to put the pellets in, which isn't a really difficult thing. But so a lot of times out of ease, we end up falling into 2 classes of medications. But these lists are available everywhere. And on UCSF website, literally it says, what hormones do you start with? And it lists them right there for you. It lists doses, and it lists how to increase the doses. Medicine trans females may be on. We talked about estrogen. Oral is the cheapest. Transdermal is probably the safest. All the studies around risk and benefits of estrogen therapy in the trans population right now mostly come from the Women's Health Initiative and the HER studies. They're only since around 2009 or 2011 have we started to get studies within the transgender population. Asherman in 2011, probably saying name incorrectly, but in 2011 had followed transgender people for 18 years looking at cardiovascular mortality risk and found that to be about 6 to 8% in transgender females taking estrogen, the overall cardiac mortality risk. That goes significantly higher if you are over 40, if you're a smoker, if you have hypertension, if you have diabetes, just like when we're talking to people for post-hormone menopausal therapy. Transdermal probably better. Interesting enough, in that 2011 study, following people for 18, overall mortality risk highest for suicide. More than any other cardiovascular risk, cholesterol risk, DVT risk, any other risk, it turned out it was suicide. And so withholding medicines is probably more harmful than giving medicines despite their risks. We do use anti-androgens, spironolactone and finasteride, and we use progesterone some. We don't know a lot about progesterones in this population. Is there an increased breast cancer risk if we're adding the progesterone and the estrogen together? I'm usually using prometrium, 100 milligrams or 200 milligrams if I am using progesterone. Some trans women like progesterone at the beginning because it can speed up nipple changes and breast development, and then we pull it away afterwards. Some women like the progesterone the entire time because it feels physiologically better to them. Micronized form of progesterone has significantly less side effects than the old-time Provera, and not many people are using that very much anymore. Remember, progesterone can be peanut oil-based. Some of the estrogens are peanut-based in the oil. Same with testosterone. One of them is cottonseed, so just make sure you're looking at allergies. And feminizing hormone changes. There are irreversible and there are reversible changes. So remember to go over those with your clients. So when you start hormone therapy, talk. The one in both trans male and trans female that you need to be talking very early, even with your teen groups that you're using gonadotropin, releasing hormone, kind of anti-puberty stuff, is fertility. Fertility, fertility, fertility. Because we don't know what these hormones do to fertility when you take them long term. So if you take testosterone as a female for 10 years and you come off of it, can you quickly become fertile again or not? And that has something to do with your own fertility, right? Or we don't have the data yet around that. Same the other way around when I'm adding estrogen to someone who has not had gonads removed long term, will their sperm, if they come off, be sufficient enough to provide pregnancy later? And we don't really know all the data. We know that when someone is on hormones, let's say a trans male, that we can't guarantee that the testosterone is enough for fertility, so to protect them from fertility. So we should be looking at contraception still for them if needed, because some trans males on testosterone still have vaginas and have sex with people who identify whatever way but have a penis. And so you have to ask those questions. You have to find out, what do we need? You need to be safe, because testosterone, just because you're not having periods doesn't mean you can't get pregnant. And so I'm doing a vasectomy on a trans female in a couple of weeks who is on hormones. So ask those things, think about them, but fertility, talk about cryobanking early if you need to. The UCSF site has a list of places around the country that can help with that, not available in Missoula. You can find timeline of changes. So if your clients are saying, but is this happening fast enough? Don't I need to go up on my therapy? What really I tell people is, 3 to 6 months is kind of normal. Dr. Ravitz has a great saying. We had a Butte farmer come in and, 48, wants to change, express himself now, female, wants to start cross hormones. Right from the get-go, Ravitz is like, you look that person in the eyes and you say, you are a 48-year-old biological male. I am never going to be able to make you a 18-year-old female. Like, be very honest with expectations, right? So if you're honest with expectations for people, then they understand that this takes a while. Risks around trans female medications, DVT, stroke, more DVT, VT. But remember, most of that data comes from the HERS and the Women's Health Initiative, not from the transgendered population. Definitely people gain some weight at the beginning of their hormone therapy. They can get gallbladder attacks, just like when you're adding estrogen for anything. You watch their triglycerides, their insulin. Very rare cases of prolactin increasing, so think about that. I usually check prolactin once. After that, I don't keep rechecking it unless there seems to be nipple discharge. We don't really know breast cancer risks in this population. I don't think we know that 100%. Don't forget all the different surgeries that can be offered. Remember, for trans females, you can get breast implants. When people are post-op, they usually, if they are post-op with gonadectomy, they usually can decrease their hormones significantly. So keep that in mind. Just don't forget that it might be your job for someone who's new in the trans community. Actually, I find all of my trans clients are way more educated on all of this than I ever am. I'm there to help guide them risk and benefit analysis, but most of the people who come into me are a lot more educated on all of this. But it is my job for this newer youth population to make sure that families understand what are surgical options that are out there because they might not even know it exists. Males, it's mostly testosterone, and IM is the cheapest. New studies show that sub-Q can be used just as well as IM. It's not standard of care. It's not written that way on the FDA paperwork. And if people are using sub-Q, quite often they can use a lower dose, about 3/4 of the dose that they would if they were doing IM. Sub-Q is nicer to give. I have lots of people that I've offered that change to them, and they want to stick with their IM. Sometimes I'll do IM for the first 6 months to see transition, and then I'll switch to sub-Q with people if that's what they prefer. Don't forget when you're prescribing all these medicines, if you're prescribing IMs, to make sure that you're also prescribing needles and needles and syringes, because many pharmacies will flat out, depending on their openness, flat out refuse needles or syringes for something that obviously needs needles and syringes unless you write a script, and it's another way to withhold medicine from someone. Strokers, am I saying that right? Strokers, who knows that pharmacy that I'm talking about? Nobody? In Portland, so there's a compounding pharmacy in Portland that many people in Missoula use, especially if they're uninsured, that can give the same, very close same medicines. They specialize in trans compounding hormones, and so I feel comfortable with their dosing, but it's a more affordable way to get the medications if you don't have insurance within this community. And then irreversible and reversible changes, again, talking about fertility. And going with the timeline again, and remembering if you're older, that timeline is longer. And look at the slides and go to the site, okay? That's the real gist of the talk. Risk of trans male medication, the one I see the most is polycythemia. That happens pretty regularly. If it gets too high, then you're afforded a risk of coagulability. However, you don't have to stop hormones because someone's red blood cells start to increase. You might decrease dosing, but you don't have to stop hormones. For me to stop hormones, example is I have a person who comes into me, has been transgender, female for a very long time, had a stroke, is still transgender female, previous physician refused to continue hormones. This person said, let me have another stroke and die if I can't be who I'm supposed to be. I understand the risk of another stroke is extremely high. You cannot take my hormones away. So do I withhold hormones or do I lay out risk and benefits and give hormones? Sleep apnea in trans males too. I think a lot of people forget that one. Lots of surgeries, female males to have. If breasts are being removed in town, we do have surgeons that will remove breasts for the trans male population. If they have very small breasts, quite often, usually just plastic surgery is needed. If they have bigger breasts, you need both a general surgeon and a plastic surgeon to go together in on that surgery. But if they're very small chest to just start with, sometimes you can refer just to plastic surgery. It can be done as one. Don't get so caught up in managing risk of the hormones that you forget that there's a real person that needs all the regular preventative stuff. So transgender people receiving medical care are like half as likely to get pap smears, half as likely to be referred for colonoscopies, to get regular vaccines. Even the transgender 11-year-old I saw the other day that we started the conversation about Lupron on left, and then I was like, oh, I didn't even say anything about Gardasil. And this is a non-sexually active client right now in the population that I should have been. We say Gardasil to everyone that walks in my clinic, so don't forget that preventative stuff. Children and teens, they can present as early as 2 to 3 years old. talked a little bit. We use puberty blockers at Tanner 2 and 3, and then start trans hormones between 14 and 16. Endocrine Society says 16. Standard of care is becoming more at 14. This is also on the university website. And then the older population, more risks. And why does it matter to you? Make sure that you're identifying people with proper pronouns. Make sure if they're seeing you for something, I'm here for a sore throat. Does it matter if they have a penis or a vagina? No. I'm here for pelvic pain? Yeah, it kind of matters, you know, or I'm here for lower abdominal pain. So you need to be open and honest with people about what their anatomy is. If you can't tell externally, which honestly, we can't ever tell. So if someone comes in and they've written on their history transgendered, and so I think we have to remember that our medical and EMR forms need to start reflecting this. Open Aid Alliance uses, I am currently male-bodied, I am currently female-bodied. They have check marks for that instead of the word male and female. So that gives a trans person the ability to say, this is what my current anatomy and body is. But sometimes you got to ask. I've had people come in that are transferring from somewhere else. I have a beautiful woman that comes in. You would look at her, you would say, beautiful woman in our stereotypical American minds. That's what you would say. And I have to say, okay, you want to continue your hormones for what have you done? What is your anatomy? I don't need to say, take off your clothes and let me see it right that minute. This is our first visit. But I need to say, have you had surgeries? What are the surgeries? Do you still have ovaries? I need to know all that so I know what preventative to give. Speak up if your coworkers are using inappropriate language, because if you don't speak up when you hear it, no one will speak up. And so if you hear inappropriate coworkers, or they come out of a room and there's a giggle or a laugh, and sometimes that's out of just uncomfortableness or lack of knowledge, not really meant to be harmful, but speak up. If you hear that, speak up with them. Be open and understanding with your lack of medical knowledge in this arena. It's new for most providers out there. So it's okay to say it's new. I'm learning about it too. We'll learn together as you're my patient. And so I am not an expert. I'm a cisgendered person who sees herself as a woman, a doctor, and an advocate for non-judgmental quality health care. It was way faster than it was supposed to be. The big gist is the information is all on the web if you need it. It's not hard to learn. Don't withhold medicines because you feel like your knowledge is lacking. You don't have to refer to a specialist, but we do have specialists or people that have more knowledge in this available in this community to ask questions to if you need. Remember that risk of suicide. Change your language. Stop the assumptions. Da-da-da. All right. If you have questions, you're welcome to stay. Many people have obligations, so run if you need to.
It strikes me that having to give an ICD code of gender dysphoria is incredibly judgmental. Is there some effort to change it to gender fluidity, or?
That it was such a long battle to get to, from my understanding, not being someone in the world. I mean, I was in Africa 70 years ago when all this was starting, but it was such a battle to change it from gender identity disorder to gender dysphoria that I bet we're a little ways off before that changes again. And so, you know, my clients quite often request records when they're doing, and so I'm quick to ask them if they want me to use endocrine disorder not otherwise specified, or if I'm using gender dysphoria. Some of them like gender dysphoria because they think it puts it on the table easily for a referral basis to know, and that it makes insurance get it more. I had a person yesterday that's intersex that was refused testosterone without had to be off his testosterone for 2 weeks and get a testosterone level that said it was low before I could continue his testosterone. His gonads were removed, his testicles were removed when he was 2, and he was given cross-gendered hormones by his family. And then he had a vaginoplasty, and then when identified himself male later in life, reverse the vaginoplasty is living as his true identity, male, and because I was writing endocrine disorder not otherwise specified, we had to fight. He's been on hormones 10 years, new insurance company, we had to fight, where when I write something like intersex or gender dysphoria, or for him I wrote diagnoses of, I can't remember, something to do with your gonads not being there anymore. Can't remember what I wrote. Like he gave me very clear, like, let's put this on it. So right now, gender dysphoria, most insurance companies are starting to recognize, oh, this might be someone who has a legal male name but still needs a PAP. Because right now our billing gets all the time to send back, to send back, to send back. We're not paying for this because why would you PAP a male? And I'm like, oh my God, read the diagnosis. And so using that, so right now I think it's kind of settled for a little bit.
Do you think the suicide rates are going to improve if physicians become more sensitive, or is it a general cultural problem?
You know, I don't know. Dr. Ravitz and I have had this conversation before because we have both had clients that in no way had discrimination within our clinic, hormones right away, and still there was a mental health depression, because transgender people, just like any person, can still have a mental health diagnosis. But that internal turmoil might still be part of it. I think what is going to help is the non-silencing of youth. So I think the sooner that within our youth population this is acceptable, and people are very scared, and this is a whole other hour talk, but people are very scared about youth. What if we're making the wrong decision and they aren't really this? And there are even transgender youth that their parents were huge advocates and now have gone backwards and say, I've done my cross hormones, I haven't started surgeries, I don't feel like I want to continue on this route. How do I come out to my parents that were such great advocates for me that all that advocacy they did might not be right? That's actually rarer than people think. It's something like 65% of people that start on, youth that start on transgender cross hormones continue on that journey, and about 35% don't. So. Well, I do that with their parents, just like I inform consent with if I have a 14-year-old that I am starting on a blood pressure med. Well, you know, it's a tricky place before age 16 here in the state. And so it's, yeah, and so it's not considered, it is, no one's made the attempt yet to call it, you know, it's not an STD, it's not a pregnancy related, it's not that I could probably use mental health as the reason, you know, but if that child is living within that family, and you're going to start hormones, there's going to be physiological changes. And if you haven't addressed that before, then there's going to be consequences afterwards. So right now, my job is that team that comes in that identifies privately to me is how can we bring that family in a safe environment, or is this a team that isn't going to be in a safe environment and needs to look at early emancipation when they can, or foster home or group home.
Are you finding that most health insurances, including Medicaid and Medicare, are covering surgeries, breast reconstruction, and where do you send patients for some of the bigger procedures?
So there's a website called Trans Bucket that has a list of all the surgical referral sources. The Gender Expansion Project here has a list of surgical referral in and out of town. I send a lot to Seattle. Some people go to Canada. Some people go to San Francisco. Some people go to Chicago. So Trans Bucket and Transgender Alliance have a good list of referral sources. In town, I use plastic surgery and Dr. Sue and Dr. J for breast. I don't have anyone that's doing bottom surgery for either side, you know, in town. So people are traveling for that. Medicaid is funny. Medicaid pays for hormones now. We just had our first giant battle with Medicaid over Lupron, because Lupron is up to $2,300 every 3 months. And so we lost the battle for Supprel in LA for a teen in a group home that's on Medicaid. So I could not use the long-acting 1 year puberty blocker. Interesting enough, Aetna has pretty good coverage right now for trans surgery and reassignment. They have a few stipulations that are not medical stipulations, but like time that they've been on hormone, and they still want a psychologist review also. Blue Cross Blue Shield is not good. There's one other that's pretty good, Alliance or something. There's a couple that are good, so it's a little back and forth. Okay, let's see. I'll come answer your question by yourself. You know that, so.
I'm running.
Okay. Our D